Terus cakap. Hello. Assalamualaikum. Jadi.
Okey, dengar atau dengar.
Dengar. Okey. Thank you.
Okey. Tunggu MC datang dah tu dah.
Okey.
MC tak datang lagi. Ada tu? Ada. Oh, presenter daripada rumah. I see.
Apa present?
NS.
NS. Alright.
Ada tu? Ada. Presenter daripada rumah. I see.
Dia room.
Cuma stop video. Oh, video. Saya buka mic. Saya buka mic. Buka. Coba saya buka mic. Buka sini. Bunyi lagi ni. Kakak masuk pun. Kakak pun belum. Kakak masuk pun.
Tak makan.
Yang mana tadi?
Buka, dia buka.
Kita kalau boleh nak yang
Bismillah, bismillah. Audio dengar kan? Audio dengar? Ladies and gentlemen, we are about to begin without begin to CME today. Please be seated and fill the first row first. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh. And a very good morning to our honorable guests, Datuk Dr. Hajah Salasawati binti Haji Ghazali, Hospital Director, Hospital Haji Perempuan Zainab 2. And then Dr. Nik Faizal bin Zainal, Deputy Hospital Director. Dr. Tengku Anas Fatihi bin Tengku Ahmad, Deputy Hospital Director 2. And then Dr. Nur Zilawati binti Muhammad Ghazali, Deputy of Hospital Director 3. And then Datuk Dr. Haji Ahmad Razin bin Ahmad Mahir, former of Director Jabatan Kesihatan Negeri Kelantan. And then all head department and specialists who attend CME today. Today I am Ahmad Zaim bin Ishaq from Emergency and Trauma Department. Will be MC for CME today. Before we start our CME today, I would like to give a few announcements regarding flow of CME. Kindly scan QR code on the screen for attended, and then QR code will display before and after the session. And then any questions regarding our topics today can ask at the chat box at YouTube link. And then kindly silent and mute your handphone to ensure the smoothness of the CME today. We are fortunately to have Dr. Zahira binti Mukhtar, Dr. Nur Zahira binti Mukhtar from Department of Anesthesiology and Intensive Care Unit, which is will be present a topic, a date with Anaesthetist. But unfortunately, Dr. Zahira today positive COVID. We pray for her speedy recovery, and then she will be present online from online. And then without any delay, I would like to invite Dr. Nur Zahira to give a presentation. Okay, Dr. Nur Zahira, the stage is yours.
Assalamualaikum. Boleh dengar ke? Boleh dengar? Boleh. Okay. Assalamualaikum and very good morning to the Pengarah Hospital, Dato' Dr. Hajah Salasawati, the consultant, respective of head of department, specialist medical officer, house officer, and all the hospital staff. Sorry for the inconvenience today because I just have a symptom and done a saliva test is positive. So I cannot be presentable at the auditorium. So, but we still can continue our hospital CME. So, I'm Dr. Nur Zahira as an anaesthetist, representative for my department to present for hospital CME for today. My topic is the pre-operative assessment. So this is an important topic as early refer to the pre-op assessment and effective communication and team approach from the NS, surgeon and also physician can ultimately reduce the numbers of cancellation of operation. if we look from this pie chart show a cancellation of elective case in the year 2020. There are multiple reasons of cancellation of the elective operation. However, if we look here, the proportion of major causes of cancellation is due to patient is not optimized. It's encountered for 31%. So hopefully after this CME, by early pre-op assessment referral, we can reduce the cancellation of operation. Okay, adequate pre-anesthetic assessment has been identified as important factor in patient safety, and it serves to identify the associated medical illness and also anesthetic risk, which aim to reduce the morbidity and mortality. So detailed information from the multiple sources should be considered during the assessment. So what is the objective of the assessment? First is to evaluate the patient medical condition and then to ensure that it's been optimized. Second, we can plan the anesthetic technique and also the peri-operative care of the patient as a whole. And furthermore, we can develop a rapport with the patient and reduce the anxiety and facilitate the conduct of anesthesia. And fourth, we can obtain informed consent from the patient, and at the same time, we can educate the patient regarding the anesthesia and also the related procedure. So this is my content for today's presentation, which is what we doing during the assessment. For the general principle, so personnel, the anesthetic assessment should be performed by the anesthetist who will conduct the anesthesia. But if it's not possible, it can be performed by other anesthetists, but the finding need to be conveyed to the anesthetist concerned. And it is the responsibility of the anesthetist conducting the anesthesia to ensure all the issue pertaining the assessment have been addressed. And if necessary, to repeat any element that are in doubt. For the timing of the assessment, it should be performed at an appropriate time before the surgery to allow adequate preparation of the patient. It can be done either as inpatient or at the pre-anesthetic clinic. So it is important for a patient with a significant comorbidity, which a patient have a specific anesthetic concern such as difficult airway, difficult intubation, or a patient which involve multidisciplinary management or plan for a major surgery. This patient should be referred to anesthetic clinic earlier for a better optimization of the patient. And some of the patient, we have planned for early hospital admission for further monitoring and optimization. This is indicated in a patient who have require further medical evaluation or prior to a major surgery. This example of a patient, usually we review in the anesthetic clinic. So some of the patient have underlying hypertension, and during the NS clinic, we noted the blood pressure is uncontrolled. But if we're looking at the control of the blood pressure at home, is a good control. So usually we will plan for admission earlier, 2 days prior to the operation, to look further evaluation of the blood pressure monitoring in the ward. So if it's well controlled, we will proceed with operation. If it is still uncontrolled, we can refer earlier for further optimization before the operation date. And the admission should not solely for the pre-operative investigation, as it can be done as outpatient. And for daycare surgery, they have a specific guideline for daycare surgery. But what I want to highlight here is any patient scheduled for the daycare surgery must refer to NS clinic prior to the operation date for assessment and optimization. So during the assessment, multidisciplinary management is sometimes needed, especially in a patient with significant comorbidity. However, the responsibility to determine the patient fitness to undergo the anesthesia still rests on the anesthetist in charge. Okay, detecting disease and assessing the severity during the assessment. This can be done by thorough assessment of the patient medical condition by means of the detailed history, physical examination, and also the relevant investigation. So patient medical history provide a vital information to identify disease that may affect the perioperative outcome. System review should focus on those pertinent to the anesthesia and also surgery. So usually we need to get a thorough history from the patient, the current and the past medical condition, any complication of the medical illness, the medication, the past and current medication, compliant to the treatment, any allergy, and also the anesthesia history. And during the assessment also, the medical record, previous medical record is also important, especially in patient with history of multiple operation or multiple admission. So by looking at the previous notes and also the previous GA form, general anesthesia form, we can know the previous anesthesia technique, any previous difficulty during intubation or difficulty in the regional anesthesia, which can help to further management of the patient and reduce the morbidity and mortality. For each assessment, the physical examination must be done thoroughly from head to toe from every system, not just assess the important vital organ. So by examination from head to toe, we can know what is the current patient issue and the complication of the underlying illness. The airway assessment is also very important. And the other thing is the surgical site, the operation site that plan for operation. So during the assessment, we must know where is the site of operation, what is the size of the lesion, what is the extension of the lesion, so we can plan for our anesthetic technique. So investigation will complement the history and also physical examination. So the investigation depends on the first, the ASA classification of the patient. Second is the surgical procedure with regard to the nature, extent, and also anticipate duration of operation. And nowadays is the COVID testing. Okay. After we detect the disease and know the severity of the disease, we need to do a risk assessment and risk stratification of the patient and disclosure. So factors such as complexity of the surgery, urgency of the surgery, surgical skill, and factor related to anesthesia contribute to the determinant of the perioperative outcome. The American Society of Anesthesiology physical status classification is used to assess the preoperative condition, and it have a predictive value for the operative mortality. So the severity of a particular complication include death or disability should be considered in the discussion, even it may be unlikely to occur. So if we look at this picture, this is the standardized ANES consent by the Kementerian Kesihatan Malaysia. If look at the consent here, it's stated from a common complication that will happen to the rarest complication that will happen. So every pre-anesthetic visit, we will inform all these complication that will occur to the patient. And then patient with significant comorbid and high anesthetic risk should be counseled and also offer an alternative surgical and anesthetic option. And it should be discussed with the patient and also next of kin. So for the risk assessment tools, as I mentioned before, we use the ASA physical status classification. Other than that is the metabolic equivalence scoring system and bedside airway assessment. If the patient was unable to assess the functional status, such as patient with bed bound, the patient cannot do exercise or strenuous activity, usually we refer for further assessment by cardiac assessment. Okay. So this is the ASA physical status classification. There are 1 to 6 and also E for emergency. This ASA classification, we can see there's a predictive percentage of mortality rate in elective and also emergency. If we look from ASA 1 to 3, the percentage of mortality rate for elective surgery is double up for the emergency. For ASA 4 and 5, is around the same. So let's go through one by one what is the ASA classification all about. ASA 1 is a normal healthy patient, and also is important is a normal BMI. So that's why the body weight and also height is very important to be noted during the preoperative assessment to calculate the BMI of a patient. And also because of nowadays, our population tend to the percentage of obesity is increasing. So ASA 2 is a patient with a mild disease without any limitation in the functional status. Smoker, pregnancy, obesity, BMI of 30 to 40, well-controlled diabetic hypertension is fall under ASA 2. ASA 3 is we're dealing with a patient with a moderate to severe disease with have some limitation of functional activity. So it is in the patient with a poor control diabetic hypertension, COPD, patient with morbid obesity more than 40, also under ASA 3. Other than that is a patient on pacemaker, moderate reduction of ejection fraction, patient with ESRF with a regular dialysis, patient with history of MI, CVA, and TIA, which is more than 3 months. If for obstetric patient, the preeclampsia with severe features, gastroenteritis with complication or high insulin also under ASA 3. For ASA 4 is a patient with severe systemic disease which constant threaten to the life. So it whereby a patient with a recent MI or CVA less than 3 months, patient with ongoing cardiac ischemia, patient with severe reduction of ejection fraction, and also patient with shock, sepsis in the IC. ASA 5 is a moribund patient which not expected to survive without the operation. This example of patients such as ruptured aneurysm, either abdominal or thoracic, patient with massive trauma, intracranial bleed. Uterine ruptured fall under ASA 5. And ASA 6 declare brain death and for organ donation. So okay, other than that, the functional capacity also can be expressed in the metabolic equivalent level. So this is the metabolic equivalent scoring system. It equal to 1 MET. It represent the oxygen consumption of a resting adult. So usually we want a patient more than 4 MET. If both both perioperative and both perioperative cardiac and also long-term risk are increased in patients who are unable to meet the MET more than 4. And then for the risk reduction strategy, after assess and risk stratify the patient, we plan for the operation. So we optimize the patient medical condition and plan for the mode of anesthesia and also analgesia during the assessment itself, and plan for the pre-medication and justify the patient own medication. This is very important because we must know the patient current medication. So we need to check every medication, which one need to be continued and which one need to withhold prior to the surgery. And then inform the fasting guideline and plan for the post-operative care, either need an ICU or HDW backup. Other perioperative management that can be done is advice on the cessation of smoking. This is very important, and this can be done early with the help of the primary team once the plan for operation. So surgeon can help to advise the patient to stop smoking at least 6 weeks prior to the operation. And further regarding the smoking, you all can refer the guideline. We have a quick smoking guideline for the perioperative patient for anesthesia in our hospital itself. And then we also can plan for the refer early for the chest physio, breathing exercise, incentive spirometry for a specific patient, such as patient plan for major surgery, patient with the operation of abdominal surgery. And we can also refer to limb physio, refer early for the nutritional support, plan for the prevention of the DVT, and arrangement with blood bank regarding the blood and blood product according to the MS POS. So patient who scheduled for the operation are fasted to avoid the risk of the regurgitation and also aspiration of gastric content during the anesthesia. So this is the Malaysian guideline for the pre-operative fasting. It's applicable to a patient with a known risk factor of aspiration. So for children, usually we do a staggered nil bimap, which is clear fluid for 2 hours, breast milk for 4 hours, formula milk for 6 hours. While in adult, usually we NBM for 6 hours prior to the surgery. So proceed with the consent. The validity of the consent must be taken during the pre-anesthetic assessment, and the consent is valid as long as the patient condition is not changed. So for underage patient, it should be taken from the parent or the guardian. So this is the consent for anesthesia. I think everyone is familiar with the consent. The front page mention all the risk factor of this is the general anesthesia and this is the regional anesthesia. And at the back is for the patient to sign and the doctor to validate. Okay. So now we go to the investigation. So the nature and extent of the pre-anesthetic investigation depend on the patient age, comorbid, as well as the nature and extent of the operation procedure. So the routine investigation listed in the table 1 solely based on the age and nature of surgery for asymptomatic patient without abnormal clinical finding. So usually the routine investigation for blood count, renal profile, ECG, and chest X-ray is indicated for the patient with the age of more than 40 and also a major surgery. If medical condition is present, relevant investigation irrespective of the age and also type of the operation should be ordered. So for example, if the ECG and chest X-ray are indicated for a 20-year-old patient with a mitral stenosis or atrial fibrillation who's planned for hernia operation. So this table show some of investigation and their indication related to the finding. So nowadays, if we do the pre-op assessment, we tend to look at the doctor taken all the unnecessary investigation, which is after this we can reduce the unnecessary investigation. So anemia. So I go a bit about certain investigation. So anemia, the WHO define anemia as hemoglobin level less than 13 gram per liter in males and 12 in a female. So anemia is not just a reduction in hemoglobin, but it's associated with the oxygen carrying, and if there's anemia, there's will associated with reduced oxygen carrying capacity of a blood, which lead to increased cardiac work and also myocardial ischemia. Any patient with hemoglobin less than 10 gram per deciliter undergoing major surgery with possible significant blood loss should be discussed with NS. And if patient have anemia, should be investigated before the operation, and can consider the treatment such as oral iron, IV iron, or in our hospital we have anemia clinic. You all can refer to the anemia clinic for further management. A bit for guideline for the transfusion of the PEG cell. Patient should not normally be transfused if hemoglobin more than 10. And a strong indication for transfusion is if hemoglobin less than 7. And symptomatic patient should be transfused. Okay. This is some investigation that I want to highlight. The electrolyte have an important role of the body. So we want a normal level for elective operation, such as sodium is 135 to 145. This is very important in the instability. If there's a abnormal result, it will have implication during the surgery. It will cause instability in the circulation on CNS. Usually, if sodium less than 130 or more than 149, need to inform NS. So it also will associated with the anesthesia in terms of patient delayed awakening after the general anesthesia. So for the potassium and calcium, what's the very important? It involve the cardiac. So if potassium is low, it will cause cardiac arrhythmia, cardiac arrest, muscle weakness, and also it will have problem with the muscle relaxant that NS given. So for the calcium also will impact the cardiac contractility and cardiac output. It also will impact the coagulation. So for the urea, the elevated urea will disturb and interfere with the elimination of the drug. And we order for creatinine to look at the severity of the renal impairment. Okay. After done a thorough history, examination, investigation, and plan for the re-stratification, and we need to done a proper documentation. Summary of the assessment, order, and arrangement should be documented properly. Instruction to ward staff regarding patient preparation must be written clearly, such as example, any repeat investigation if necessary, and then the GSM blood needed as per MS BOSS, and the blood product type and quantity must be written clearly. Time of fasting, especially in children, that we do a staggered fasting. Medication, which one need to be continued and which one need to be omitted. on the day of surgery, and pre-medication, that NS order, the dose, route, and time of administration, we usually clearly written in the general anesthesia form. So usually after NS assessment, the primary team need to take a look at the form. So until now, is there any question before we go to the COVID-19 issue? If there's no further question, so I will go to the new norm is COVID-19. Almost 3 years we already dealing with the COVID-19 infection. So the COVID-19 infection can affect all the major organ system. So sometimes post or COVID-19 patient will have residual symptoms such as fatigue, shortness of breath, and chest pain are common and can affect up to 2 months or 60 days. So the timing of surgery after COVID-19 infection must take into consideration the risk of the perioperative complication due to residual organ dysfunction. And non-urgent surgery or procedure should be delayed until the patient is no longer infective and has resolved from the complication. So for the COVID-19 information, it change from time to time. This is the latest update in 23rd February regarding the isolation period for a COVID-19 infection patient. So the isolation period is depend on the patient clinical category, vaccination status, and also period and either the patient fully vaccinated or not fully vaccinated. So for the category 1, which is fully vaccinated, just need 7 days of isolation. Not fully vaccinated or unvaccinated, vaccinated is 10 days. Category 2, fully vaccinated 7 days, not vaccinated is 10 days, same as the category 1. And for category 4, 5, either is vaccine or not vaccinated is 10 to 20 days. So if the patient still in isolation, any operation, emergency operation that been scheduled need to be done in the OT virus. So after the patient is de-isolated, we can proceed at the general operation theatre. That applicable for the emergency surgery. However, for the elective surgery, the duration need to be delayed. If patient is asymptomatic and recover from mild or non-respiratory symptom, we suggest to postpone at least 4 weeks. If patient with symptom and did not require hospitalization, suggested to postpone 6 weeks. This is for elective operation. If symptom and require hospitalization in patient with diabetic and immunocompromised, 8 to 10 weeks. And critical ill patient is 12 weeks. But this one is varies. If a patient require elective surgery, such as a patient with malignancy, and sometimes we need to discuss among the surgeon and also anesthetist either to proceed with the operation and not follow this waiting time. For COVID-19 testing, if the patient present less than 90 days after positive COVID-19, the retesting is not recommended. But if the patient present within 90 days post-infection and has a new symptom consistent with the COVID-19 infection, first need to immediate isolate the patient and consult the infectious disease consultant or physician. And then surgery can be rescheduled only when reinfection is excluded and the patient is discontinued from the COVID-19 transmission-based precaution. Once the 90 days period is over, the standard pre-op COVID-19 testing guideline should be followed. So the pre-operative assessment for post-COVID patient is just the same as the normal patient, but in the post-COVID-19 patient, there's a further thing that we need to clarify, such as during the history, we must ask thoroughly regarding the discharge summary from previous treating facility, the category of the infection, medication that patient is on, and the imaging report. So we must know if there's in any imaging report have been done, what is the complication, such as any CT scan have been done, is there any organizing pneumonia, is there any pulmonary embolism of the patient. We also need to assess the present functional status in performing daily living activity, as COVID-19 will affect the patient functional status. Is there any post-COVID-19 infection, such as pulmonary embolism and so on? So any chronic steroid use with post-COVID related lung disease, any anticoagulant that patient is on for the pulmonary embolism, myocardial infarction, and also CVA, and any home oxygen therapy. This must be emphasized during the assessment of patient post-COVID compared to the normal patient. And then the physical examination is just the same as a routine assessment, and the pre-operative blood test and imaging as tally with the patient presentation. And informed consent in a patient with COVID-19 include the increased risk of the perioperative cardiorespiratory and complication and possible ICU stay need to be emphasized to the patient. Okay. So is there any question?
Yeah. Okay, thank you.
Thank you, Dr. Zahira, regarding the interesting and knowledgeable presentation. So for the audience from online, kindly drop your question at the online chat box. And then from the hall today, if any question can ask.
Okay, Assalamualaikum, Dr. Zahira.
Yeah.
Can you hear me?
Yeah. Boleh.
Okay, thank you so much. And first of all, thank you for the presentation. Lebih clear lah sebenarnya ya, khususnya kepada jabatan-jabatan ataupun the primary care department, ya, the surgical based primary care department, and especially to the young doctors, what you have to and what you don't have to do. Ya. Okay. Number 2, I wish you well, speedy recovery. Only 7 days. Jadi begitu berharga. We need to come back as soon as possible. Yeah. So, okay, number 3, there are a few things. Yeah? Number 1 is one of the few things of the third part ni lah. Ya? Yang pertama sekali, kita tahu dia tangible and intangible dalam bila berlakunya cancellation of cases. Okay? Tangible ni benda-benda yang very objective as you mentioned. Ya? The intangible is actually communication. Ya? Kita dapati banyak grounds ya, di mana apabila pesakit tu tak dapat proceed dengan surgery ya, maybe the message only convey cancel, operation cancel ya. But it was not clearly explained. Maybe you explain, mungkin mereka pun tak sempat nak tengok the document, as you mentioned that everything should be document, then the primary team should read the document. We have written everything well spelled in the document. So saya rasa peringkat itu belum belum sempat dilihat oleh, sebab the receiving actually more on the nurses. Masa ambil balik kes ke ataupun cancel the case ke, sama ada at the OT site ke ataupun before operation lah. Before operation, one of the common cancellation yang saya tak dapat di sini adalah no OT time. Okay, no OT time is one of the common. And apart from the pre-op assessment lah. So with regard to the pre-op atau assessment ni, kita rasa cakap intangible tu bukan senang untuk pesakit kita yang dah end up di hospital, kemudian dengan semua wari-wari mari belakang ini, ambil cuti dan sebagainya. It's not easy for us to explain to the patient and to the relatives. Sebab itu, I come back to number one tadi, communication tadi. Betul, NS plays a gatekeeper. But at the end of the day, the entrusted person are the primary team. Primary team yang the family basically deal with the primary team. The primary team. Ini yang satu perkara yang we should improve. I must say that we should improve this communication. Because dia melibatkan satu, that's number one. Number two, we have good guideline ataupun outline very objectively your do's and don'ts dalam procedures. Tetapi it do come across different anesthetists ataupun different enforcer, different registrar, they have different the interpretation of to cancel or not to cancel. Sebab tu kita dapat isu kalau dengan MS ni okey je, kalau dengan orang ni tak okey, kalau orang ni asyik nak cancel je. So these are the things yang kita rasa kita kena minimize, kita kena mengurangkan this. Kalau kita dah ada satu standard, satu guide kan, by right, regardless siapa lah Datuk Wan ke, Dr. Mazlan ke, siapa ke, so you play the same role actually. Tidak ada isu kalau dengan orang ni okey je, dengan orang ni tak boleh pula kan. So too high and too low of the threshold tu. So of the consideration. So mungkin number one is the communication. Number two is that applying a same standard almost applicable anytime, anywhere, by anybody. So mungkin kalau Dr. Zahira tak jawab pun, Dr. Nas boleh jawab di sebelah saya.
Assalamualaikum. Saya sebenarnya terpaksa menghentikan sebab ada webinar, tapi saya perlu menjawab mungkin nombor dua, mungkin nombor satu, Dr. Zahira boleh jawab. Okay, so we are actually about the purpose that I think NSK started way back in 2000, 2002 when I was in KL, dan IPA were very sentimental about having NS clinic. By right, kita nak semua patient get NS clinic, and we are very sad that macam Datuk kata, bila patient terpaksa kena be cancel, and we are looking very actively on that ground. Okay, regarding the differences, okay, the purpose of the NS clinic is actually to make sure to minimize apa-apa yang perlu optimize, kita kena optimize. So by refer kat sana, all those things. So okay, so by right on that ground, kita memang reduce the cancellation, and it's definitely can reduce very much. Semua masih ada isolated cases, a few cases yang plus NS clinic, plus tak perlu ICU, kadang-kadang kenapa tiba-tiba on that day actually di cancel. Dan memang saya pun baru jadi kepala jabatan pun dah kaki kanan kena menerima phone call lah, to the challenge of HOD lah. Okay, semua satu, okay, sekiranya condition change, I mean definitely tiba-tiba electrolyte change ke ataupun condition change, definitely kita kena, the change in the practice, it cannot be standardized. Pas kat sini definitely just satu. Yang kedua, kita kena faham, okay, by right it should be standard, tapi kadang-kadang ada certain condition that because whatever it is, it must be the especially that run on that day too. Is the one who are actually running macam pilot lah, mungkin pilot yang tengok sebenarnya otomatik kayak skru logistik dan dia pakai ini lah. Cuma we going to take an active measures whoever that case actually be cancelled, kita akan cuba discuss at our department level to make sure that we especially to be on the same ground, the same concern, and then kita iron out all the things. Okay. So from now on, saya akan cuba tengok case yang been past anesthetic tapi kena cancel kenapa, and then we should sit down together and discuss on that ground. I think mungkin Dr. Azhar ada komen. Dia tahu.
Masalah ada patient condition is dynamic. Bila kita kat tengok kat patient kat KNS ni, patient anaesthetist, and then bila masuk ward, sometimes that patient emotionally down, and then sometimes kita repeat all the investigation, and then sometimes most of the patient actually fail, and then sometimes memang ada discrepancies around our decision. Tapi ya, for the sake for the patient, sometimes kita rasa tak feeling tak sedap kalau tak ada juga. That's why some anesthetic rasa nak isi back, sometimes tak isi back. Kalau mesti sometimes decision tu right. That's why bukan sisi kita saja nak cancel kita. So for the sake of the patient, to avoid any mortality or morbidity post-operative interruption. Sometimes that's why kita ada HBM surgery for that to reduce the cancellation.
Ada beberapa sakit yang di cancel berulang kali. Berulang kali dalam cancel. Sekali, 2 kali.
Tapi biasanya kalau yang cancel tu because of yang berulang kali because ada HBM. And then sometimes because ada operation pun dulu cancel, sometimes everything optimized on the table ada AM. So we have to cancel and then the next time they always go still up. And then that's again sometimes because I'm the same, not because the same problem.
Assalamualaikum, Tuan Zuki tadi. Saya nak komen yang basically komen lah. One of the reason for cancellation is medical reason yang relatively quite common, not optimized, especially elective cases. But dalam medical, we refer many of the elective cases admitted under transportation that is not fair for patient. But we do have we do provide adequate number of slots for pre-operative clinics. So every week kita ada on Thursday for information for all of you. So any cases yang pre-operatively need to be reviewed with medical condition, we have slots on Thursday, 15 slots per week. So I think that is enough for those cases elective. The other medical condition referred earlier for proper optimization of medical condition. But kadang-kadang bila refer elective, masuk dapat respon, dapat usaha, BP high, it's not possible to stabilize or optimize any medical condition. So, and because of that, patient will postpone this simply because of that. It is not fair for patient being admitted for that reason. Itu satu. Yang kedua, among common requests to medical on-call, medical specialist, is basically to do echo while patient is admitted in the ward for elective ataupun emergency. There's some issue because echo request too many outpatient and inpatient, so tak boleh nak accommodate, and sometimes we feel that it's not necessary. Because kalau tengok tadi pun criteria not outpatient going for surgery should be requested for echocardiography. So there's some patient who might need to be assessed cardiologically by echocardiography. Memang ada lah, tapi kalau in general, kalau patient tu yang asymptomatic, tak ada real risk of ischemic disease, poor function, then echo should not be requested easily. Because kalau tak buat echo, kena postpone surgery. I think that again, it's not justified because by not doing echo and postpone surgery in a patient who does not require further evaluation by cardiology, I think that's not really a fair justification. So kalau perlu buat assessment buat dekat luar, outpatient. Mungkin some patient needs stress test, for example. Tak sure, so echo is static. Kadang-kadang kita tak pick up condition bila patient is static and rest. Dia tak ada changes kan. So mungkin kita buat stress test, doktor ni stress test, for example. Ataupun even up to angiogram for some patient, because they are not symptomatic, but they have some significant ischemic disease which not being able to pick up by echocardiography. So we just information with that. So kalau nak request for elective, refer to pre-operative medical clinics on first aid, as well as request according to what the patient needs. Thank you.
Assalamualaikum, Dr. Nazri. Saya ada beberapa soalan kepada presenter. Satunya pasal yang berikut chat yang blood investigation tu, most likely yang patient less than 40 tak perlu apa-apa investigation lah. Tapi kita sekarang kita buat semua lah. Kita buat result function, kalau tengok age less than 40 tidak medical, tak perlu pun. Tapi bila tak buat, dia minta macam mana nak pergi lah satu. Yang keduanya yang asal satu katanya normal BMI, tapi asal dua BMI 30-40. BMI 25-30 nak buang kat mana? Yang kedua. Yang ketiganya pasal macam cancellation because no on time. Sebenarnya kita letak kes berdasarkan apa yang kita boleh kontrol untuk OT time lah, yang sedia start. Tapi yang kita boleh kontrol adalah NS yang ambil masa, kita boleh kontrol lah. Kadang-kadang lebih dura pun sejam, semuanya itu kita tak boleh nak masuk dalam perkiraan kita, berapa banyak. Kadang-kadang cancellation case sebab tu lah. Jadi sebab yang tu susah nak cakap lah kan. Jadi macam kita ni banyak yang guna dibagi. Macam auto ni dia kurang GA, dia banyak nak bagi regional. Regional ni time dia varies. Ini gitu performa lah. Sekarang try tak boleh semua, kena ambil masa lama. So, turnover case tu menyebabkan banyak cancellation case dalam pihak kita. Lepas tu macam yang kebanyakan elektif yang semua yang ada comorbidity kita refer kepada NSP ni lah. Tapi macam tadi isu ada juga yang masuk cancer. Contohnya baru NSP ini kan kita ada slot kita masuk next week. Kita hantar juga NSP ni walaupun this week. So this week kata okey, tapi next week masuk kena repeat balik semua evaluation, nak ICU semua. Yang baru jadi juga lah, so jadi isu. Satu lagi saya minta lah yang mana pesakit yang perlu nak ICU backup semua, saya rasa minta. Sebab sekarang yang pergi tengok adalah NSFO yang pergi tengok. MO saya tak tahu status macam mana. Tapi yang tengok sendiri tengah access by phone ni dia live lah. Jadi yang mana yang perlu ICU backup, yang perlu ni saya request oleh NS yang nak buat tu, Anaesthetist lah, bukan MO saja yang access lah. Sebab kita tengok, sebab kadang-kadang yang kita nampak sakit pun kita tak ni pun, tapi yang problemnya kita tengok macam patient tu okey, tapi pun nak ICU backup based on that phone je pada dia, consult by phone. So macam yang tu dia macam tak set. Dan furthermore sekarang ICU memang susah. Macam Dr. Lagi cakap, bila dia nak ICU yang ni, next pun dia nak ICU juga. Next yang tu kita ada 3-4 kali cancer pun ada, sehingga sakit give up, tak buat operation, sebenarnya tak buat sebab patient give up lah. Sebab masuk cancer, sebab consider bagi kita operation biasa kita buat selalu. Kalau kita biasa kita buat sekejap kan, 2 jam. Tapi bagi patient, benda tu major bagi dia, panggil semua orang buat jamu berapa kali tak tahu kan. Itu cancer. Jadi itu isu yang okey.
Assalamualaikum, saya sambung terus lah. Terima kasih Mr. Nazir kerana bring up all the common issues happen in surgical based ward ataupun department lah. Saya nak sambung sikit berkenaan dengan pre-med. Pre-med which is actually done by a very junior MO NS lah, very junior. Mungkin bawah dia hospital masuk first week or 2 weeks ataupun first month to do NS dan pergi buat pre-med. And then the rate of cancellation tu very high. Because the reason why cancellation high because apa message yang di-convey kepada senior ataupun kepada spesialis dia tu based on dia punya assessment lah. Sebab itu lah daripada pemerhatian kita. Sorry to say anaesthetist kat sini lah sebab rasa kena beritahu sini lah. Ramai MO yang junior NS dia tengok pre-med. Contohnya kalau let's say dia nak assess for your RTI, patient tak ada NS, tak ada runny nose, tak ada apa-apa, cuma patient tu batuk sedikit seperti di depan dia semasa bercakap. Dia beritahu anaesthetist, patient ni ada batuk. And then straight away, cancel case. Jadi saya rasa this is very unfair. Patient come all the way from Musang ke Kolkata ke. And then without seeing, because we assess balik, so not injected, febrile atau what normal. So I think this is kalau boleh threshold tu janganlah terlalu rendah sangat untuk cancel. Dan kalau boleh seperti yang Mr. Nazir kata tadi, usually give the senior MO ataupun kalau boleh the anaesthetist in charge of the OT the next day datang terus untuk tengok sendiri pre-medication supaya nak avoid all this cancellation rate. Thank you.
Ginilah apapun yang berlaku, again the bottom line is communication. I think this is something yang that's why saya kata dalam presentation ni Zaira I wish ada you punya challenges, apa the issue dan challenges. Presentation kita ni tak boleh theoretically oriented sangat sebab banyak sebenarnya isu-isu yang surface yang mungkin kita boleh highlight what are the issues and then how do we go about in reducing, minimizing that issue lah. So this is a live that's the CME yang lebih kalau nak teori-teori ni kita boleh baca, kita boleh edar, tetapi what's happened actually itulah sebenarnya for us to learn. Saya bukan kata orang salah orang itu no point nak mencari kesalahan siapa. Yang penting sekali adalah to look back into our practice, how we can get it better. Okay, so Dr. Azhar, Dr. Wenash, and all the heads of surgical base dan kita semua lah. So we look back to have something more better, and of course not to undermine ataupun nak rasa inferior ke depan ni tak. We need each other. You are all very critical and essential. We are not alone in this journey. So semuanya penting. Semua orang ni you are too valuable for your everybody is an essential asset for this organization and the patient with all of us. Tak boleh ada adanya saja, tak ada saja, tak boleh. Ada saja, tak ada, tak boleh. We have to complement each other. That's why communication again, communicate, whom to communicate with the specialist or with the senior, the super senior. Itu yang penting sebenarnya. To prioritize. Prioritizing is very important. Now, the message going through is also sangat penting. So that the decision we make is a collective decision. Okay, so saya rasa we end up there. Okay, alhamdulillah, insyaAllah. So, Dr. Razif, anything from you? Tak ada. Ada sih.
Itulah investigation.
Okay. So Azhar jawab.
Assalamualaikum warahmatullahi wabarakatuh. About blood investigation, biasanya kalau patient fit, ASA1, and then not going for major surgery, no need blood investigation. And then kalau patient going for major investigation, even though patient muda, we ask for blood investigation. Sometimes we need echo for patient. And then lagi satu pasal, and then kita ada our latest jalan. Macam dulu kalau TSS ECG almost 60 pun kita kalau request for X-ray and ECGs. And then the other thing about cancellation because of not the time. I admit sometimes because our procedure lambat and sometimes not every patient to sit senang. Sometimes we have difficult epidural, we have difficult lines. So nampak saya pun rasa bila lambat begini. Tapi we do accommodate and sometimes we put MOs petang in order to finish on the case. Sometimes bila dah petang tu bila case dah panjang, we have to cancel because sometimes up to 9 ACC or ACC tu dah tutup. And then about the thing you mentioned about URTI symptom we have to cancel. Not for patient yang cough only we cancel. Sometimes we have to take as a whole. Makanya kalau ada 2 out of 3, sometimes patient ada liver, cough, runny nose. Kalau 2, and then sometimes we have to access the system up till tomorrow. Kita access balik tomorrow. Kalau still persist, macam ada fever, runny nose, and then terus injector we have to cancel lah. Because I feel of course sometimes some patient I come across patient dapat severe mucus masuk, sepatu itu kalau patient ada accident. So we cannot compromise the patient safety in terms of giving industrial intervention.
Finally, apa pun kita buat, everybody has their reason and their rationale why they are doing what we have to do. So objektif kita, saya kata kita ni always work with objective, sesuatu perkara yang objektif dan something yang meticulous, yang something bukan repetitive for you, but something is very significant because we are not going to take any risk. Tapi again saya emphasize communication. So kali ni yang the hidden ni yang so intangible, yang we can avoid all this just by communication. Inshallah, improve our communication. Inshallah. Okay, thank you so much.
Okay, thank you. Okay, thank you. There is one question from the audience in chat box. Dr. Zahira will answer, will reply in the chat box. Okay, next. I will invite Hospital Director, Dr. Anaesthetist, any announcement for the staff?
Okay, thank you so much. So kita tahu the COVID is escalate. Kalau saya kata escalate on what basis hari ini saja dia dah cross 114 cases itu pun kita bagi adult, pediatric, ONG case kita dapati ONG cases ni meningkat bila orang dah boleh balik kampung nak sari di Kelantan. So now it comes, of course they come to our ni yang tak nampak juga macam sekarang ni the numbers of our positive cases among staff dulu saya bilang below 10, 2, 3, 4, 5, 6, bila dah 10 tu saya dah risau dah. Tapi hari ini dah 40 sehari. So what is it significant? Yes, very significant. Sebab bukan unit tu kalau makin ramai, so it will really affect kita punya servis lah Walau bagaimanapun Kementerian telah mengeluarkan beberapa guideline yang untuk kita dapati kalau you are asymptomatic dan sebagainya sekarang ni isu close contact CC1 asymptomatic mesti to come work so everybody tengok balik guideline itu tengok balik. So kita bersyukur Omicron walaupun infectivity rate dia sangat tinggi tetapi severity dan all of us except two di HRPZ ni yang tak nak ambil vaksin tetapi yang masih belum dapat booster masih ada lagi. So please kita ni nak menghindar mudarat yang lebih besar sebenarnya. Betul, bila ambil vaksin, ada yang sedikit menerima dia punya lenguh demam pasal ambil vaksin, kita it's okay. Tetapi we want to prevent for large mudarat kalau terkena COVID dengan complication-nya, dengan severity-nya. So far, because of dengan izin Allah kita dengan ikhtiar kita dan kita mendapat booster ini, kita lihat bahawa the severity kita tengok cat 1 on 2 most, cat 1 2. So Dr. Zahira tadi maybe 2B kot, 2A kot, 2A. InsyaAllah So take care Dr. Zahira and all warga HRPZ out there yang positif. Klinik Faizal pun dah bergejala tapi first test negatif so insyaAllah alhamdulillah So take care everyone. We really need you guys and we need ourselves. Kita ni diperlukan untuk kesinambungan perkhidmatan untuk pesakit-pesakit kita. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Dr. Sawati. Okay, we are about to end our session CME today. So before I finish the CME, I would like to open if any department want to give me an announcement for HRPZ staff. Okay, for the next CME session, for the next week will be presented by ED team with the CME title of Rush Protocol. And then before I finish CME today, there is some video provided by CME team to share with the audience. Assalamualaikum and thank you.
Masalah pendengaran dalam keadaan masalah pendengaran dalam kalangan kanak-kanak. Adakah anda yakin anak anda boleh mendengar dengan baik? Masalah pendengaran adalah kecacatan yang tidak kelihatan dan kurang disadari sekiranya berlaku dalam kalangan bayi dan kanak-kanak. Ketahui status pendengaran anak anda melalui ujian saringan pendengaran. Ujian saringan pendengaran boleh dilakukan untuk semua peringkat usia seawal kelahiran. Ia mudah, panas dan tidak menyakitkan. Pengesanan dan pemulihan awal dapat membantu perkembangan pendengaran bertujuan dan minta anak anda. Ibu bapa, bantulah anak anda, jangan berlengah. Peka dengan bilik pendengaran anak anda. Kunjungi fasilitas kesihatan berhampiran yang menawarkan pemeriksaan pendengaran.
Okay.